tradition that we join a member state. Started with South Africa. Today we are joined by someone from Uganda, and he is Dr. Alex Avio, and Director of the Uganda National Institute of Public Health. Welcome, Dr. Avio. Welcome when your turn comes. For colleagues who are watching online, if you want to ask your question directly online, just use the raised hand icon. Recognize you. Also use the WhatsApp number as 251-9455-2310. To ask your questions, you can use the WhatsApp number 251-450-2310. Other announcements that I have to make is that for the first time we are 90 languages. That's a big development, and we hope getting the content coming from the Africa CDC for various audiences. So today we are coming to you in English, in French, and in Portuguese. To access the language that you prefer, look down at the bottom of the Zoom screen and select interpretation, and then select the language that you prefer. So that's the press conference today going out in French, Portuguese, and English. And you are free to select your preferred language. Finally, we are also coming to you on a number of platforms, and those include the African Union and Africa CDC Facebook pages, and also the African Union live stream channel, as well as the Africa CDC. All right, so that's our announcement. Great. Let me now welcome Dr. John Kengasong. He is the Director of the Africa CDC to speak to us. Dr. John, it's over to you.
Good morning, colleagues, and welcome to of our weekly briefing. Let me first of all start by thanking all the media, the journalists that are committed to this struggle, this fight against COVID-19, to really appreciate sincerely all what you continue to do to take out the message, the correct information to the community. As I've stated earlier and on multiple occasions, the fight against COVID-19 will be won at the community level. And the role that you play is extremely important as we tackle this deadly enemy. I would also like to thank all our partners that are continuing to support us as we roll out our partnership to accelerate COVID testing, which we launched in March. And that initiative is really going on very, very well. And I will come back to that later. Let me then transition to the epidemiological situation. Start with the world situation, then I'll go to the continental situation. As we all know that we have crossed an important milestone where about 15 million infections have been reported from about 200 countries, and out of this, about 600 deaths have occurred. When you look at the continent of Africa, as of today, this morning, about 750,000 cases of COVID infections have been reported. Out of this, close to 16,000 deaths have occurred, resulting to a case fatality rate of 2.1%. The good news I always like to share is that out of this number, that is the 750,000 cases, about 410,000 have recovered, which is very, very encouraging. That represents slightly over half that number. In the past week, In the past week, there have been 19% increase in cases, with 123,000 new cases reported, an average of 17,000 new cases reported per day. Average daily new cases from previous week was 17,300, so it's very similar to last week. Of the total number of cases, 49%, or about 223,000, are males, and 51%, about 232,000, are females. So it's almost like the pandemic on our continent is 50-50 divided. On to date, 42 member states have reported 9,000 cases among healthcare workers, which account for about 1.2% of all cases on the continent. And that is very, very concerning. We've always insisted that we have to protect our healthcare workers, as these are people that are critical not to enable us fight against COVID-19, but other endemic diseases, for example, tuberculosis, malaria, and HIV/AIDS that is already challenging us on the continent. There are 5 countries that are accounting for about 75% of all cases of COVID infection in Africa. That include South Africa, accounting for about 51% of all cases. That is, of the 750,000 cases, South Africa accounts for slightly over half of those. Egypt, 11%, Nigeria, 5%, Ghana, 3.4%, and Nigeria, 3.1%. I know the question is also very, the question on many people's mind is, what is our mortality rate compared to the rest of the world? The case fatality rate overall as a continent is about 2.3%, as I indicated earlier. However, if you look at it carefully and you unpack that, there are 8 countries with a case fatality rate that is comparable or higher than the global case fatality rate of 4.2. And I'll go through these countries slowly. Chad is reporting a case fatality rate of about 8%, Liberia 6%, Sudan 6%, Niger 6%, Burkina Faso 5%, Egypt 4.9%, Mali 4.9%, and Nigeria 4.6%. It's also interesting to note that on our mortality on the continent, that South Africa accounts for about 4,500, Egypt for about 4,000 cases of deaths, and Algeria about 1,000. So if you combine those 3 countries, they account for many more deaths, a significant number of deaths across the continent. Let me now segue to the testing and medical supplies. As a continent, we've conducted, as of today, 7.2 million COVID tests. If you all recall, when we launched the PAC initiative in March, we had committed ourselves that in the next 3-4 months, we should push the continent to test at least 10 million. So this represents a significant increase of testing over the last couple of months. And if you compare the number this week and last week, the testing number is up about 15%, which is very encouraging. We are not yet there. I mean, what would make us happy is that if we begin to test at least 1% of our continent, or conduct 1% of the testing, which will be around 13 to 15 million tests per month. 10 countries are conducting more than 80% of the tests, and that will include South Africa, Morocco, Ghana, Egypt, Ethiopia, Uganda, Mauritius, Kenya, Nigeria, and Rwanda. At this point, it is important to note that when you dissect the 5 geographic regions of the continent carefully, you notice that the Central Africa region is conducting way less number of testing. They've tested so far about 330,000 tests. So that remains a serious concern for us, and we will be focusing on that region very, very aggressively to see what we can do to increase the number of testing. It is also important to note that Africa CDC has supported the training of over 7,600 clinicians on how to manage COVID-19 cases. That is case management both at home and at hospital settings. We have also trained over 6,000 individuals on how to conduct lab testing appropriately. Let me then provide some updates on the vaccine work. As we speak, there are currently about 24 candidate vaccines in clinical evaluation globally. As we know, on the continent of South Africa has started clinical trials for COVID-19 vaccines. And we heard this week the encouraging results from some two studies that were published in the Lancet showing promising results with respect to the immune responses to the candidate vaccines that were used in that study. For example, both candidate vaccines were able to raise neutralizing antibodies, which is a surrogate for a potential protection, and then the T cell responses, which is very, very important for us to have an appropriate vaccine. That doesn't mean we have a vaccine. It only tells you that we have the correlates of a potential protection, and these vaccines will now go into large-scale phase 3 clinical trials. And we hope that the continent, through our vaccine strategy that we are finalizing, will play a critical role in this as well. So let me just conclude by saying that yesterday, the Africa Centers for Disease Control and Prevention and the World Health Organization launched a 25-member regional expert advisory committee on traditional medicine for COVID-19. And that will be, there will be an independent scientific advisory group that will continue to provide guidance and oversight over safety, efficacy, and quality of traditional medicine therapy on the continent. Thank you.
Thank you very much. That was Dr. John, the Africa CDC Director, giving us an update on a number of initiatives. Very interesting there to note the progress on the vaccine the vaccination studies that are going on, as well as the vaccination strategy that has been formulated, as well as initiatives that you have mentioned on the strategy. Now, I want to call upon Dr. Alex Ario. Dr. Alex is the director of the Uganda National Institute of Public Health. Good morning, Dr. Alex.
Good morning, Wayne.
Hope that you're well there in Uganda.
No, we're very okay, just busy.
Wonderful.
Yeah.
One of our member states, Uganda, please give us the brief from your end.
Thank you very much, Wayne. Let me begin by thanking Dr. John Pengason, the Director of Africa CDC, and the entire Africa CDC team, for the tremendous work you've done and for all the collaboration you've extended to us. Of course, I'll extend it to the African Union as well. I also want to thank whoever is listening to this presentation, journalists and then the other technical people. I'll just give you a synopsis of what we've done. We've done a tremendous job as a country. And right from the time when COVID was declared a pandemic by WHO, actually found us already in the preparedness, rather in the response phase of COVID-19, of Ebola. And so we simply transitioned to preparedness response to COVID-19. So by the time we got the first confirmed case, COVID-19 on the 21st of March 2020, we were actually fairly prepared. But of course, you know, it takes a lot of resources. Use the multi-pronged approach to respond to that. And as of end of last week, we had Uganda's cumulative number of new COVID-19 cases standing at 1,062, with a case fatality rate of 0. And this definitely includes the 1,609 foreign nationals. As many of you are aware, this was a presidential directive where we had to disaggregate data, Ugandan data and then the foreign nationals data. We're literally now reporting on Ugandan data. Most of the cases we have observed so far at the border points. This includes, of course, both Ugandans and foreign nationals. Majority of them being truck drivers. But a confirmed COVID-19 non-Ugandan truck drivers are being declined entry into the country. Time we realize that a good chunk of numbers. If you look at the confirmed cases by point of identification, airport we only identified 5. At the border points of entry is 45. The institutional quarantine 44. Including of course contacts. And then the health facility level we've had 28, but from community alert we've had 130. We also did a rapid assessment to determine community transmission. By that time, actually, we did not have community transmission. Out of 24,000 samples that we tested, those ones actually also had some epilink, some truck driver. There was really no established community transmission right then. But the situation is different now. In our data, you realize that 86%, that to 14%. The average age of those affected are 35 years. Majority being 26 to 45. The bulk of the people between the ages of 26, this accounts for about 61%. The highest comorbidities remains hypertension, followed by HIV and diabetes. And 62% of our cases are actually symptomatic. And for those that are symptomatic, the numbers are actually not threatening. Very associated. Still have sustained community. There's also an evolving shift in the number of cases among returnees increasing as a result of government permitting their entry to the country. Right? We've actually had quite a number of people. But it, of course, still calls for need for more vigilance at the entry points, especially our the airport, which is entered, to ensure that COVID-19 prevention guidelines for returnees are followed. The screening, testing, and of course, in comparison to the East African countries, Uganda actually ranks second last, with Kenya ranking highest, followed by DRC, South Sudan, Rwanda, and then, of course, last is Burundi. That is minus Tanzania, which, of course, stagnated at 509 cases. In the country, Uganda Virus Research Institute remains the main testing laboratory. We also have 5 decentralized labs at strategic points of entry. And so far, we've had 242,405 laboratory samples by that samples which had been collected and tested for COVID-19. Of these, 2,671 have tested positive. And this one, of course, is yielding a positivity rate of 1.1. Now, of these samples that are tested positive, I mentioned earlier 1,662 are Ugandans, then 1,609. The cumulative number of contacts that we've listed at the end of last week was 13,851, and a total of 12,563, which is 8% of these listed contacts are completed in days follow-up. We still have about 9% of the contacts. In total, we've had 6,615 persons isolated in 79 quarantine centers across the country. And by end of last week, we had discharged 4,933 from institutional quarantine. That means we had 1,682 that were still different quarantine centers across. We have a national call center. We also have decentralized call centers to the district. And we, of course, also noticed that there were some challenges in reporting. Some of them, of course, were limited capacity of the surveillance teams to use open data kits, then lack of internet data bundles, requirement for submission of multiple reports by the same teams, poor network connectivity, then of course lack of pay to the teams, and heavy workload and failure of the ODK server. So we of course get some of these, and then there's also need of course to network with the providers internet to make sure that activity is in. Now, as of last week, 1,226 COVID cases, including foreign nationals, that were managed at our 18 COVID-19 treatment centers. And a total of 1,048 have been discharged. Now, at the end of last week, we had a total of 142 who are still admitted at the various treatment centers, majority being Ugandans. Our total bed capacity for COVID-19 management in the country is 995. Because of some of the dynamics that we have experienced, we have stepped up communication, continued use of non-pharmaceutical intervention, like what we call the Tosemberera campaign, is a local language, continues to run on 309 radio stations across the country and 7 TV stations. In addition, campaigns focusing on COVID-19 prevention measures still going on, psychosocial support, stigma prevention, then of course use of masks, running on various things. The availability of stock is quite low. Protective gear in commodities is low, and this cannot last many months for us. There's need, of course, for additional supplies. No, there are some supplies that are in the pipeline, and by last week, community face masks that were procured by government, launched by the Honorable Minister of Health, and their distribution has started. Then we've also heightened surveillance, especially in the hospitals.
Dr. Alex,
Yes.
Alex, perhaps you can wind down.
Yeah. Actually done. So when you look at our surveillance, we've also heightened surveillance in the border districts. We've rolled out training of healthcare workers on IPC in all the hospitals, at least zero transmission of infection. Because, of course, of the increasing number of recoveries and discharge cases, we have also followed this up with provision of psychosocial support. Summary, this is actually what we've done in Uganda. Thank you very much, Gwen.
Thank you very, very much for that very comprehensive breakdown of what Uganda is doing. You've also mentioned some of the constraints that you are facing, the mitigatory measures that you are taking. We'll come back to you a bit later on with the follow-up in terms of how you are collaborating with the CDC and other countries. But for now, let us move on to the question and answer session. Before we get there, let me just remind those who might want to ask questions that, as usual, we have the 2 channels that you can use. You can do that straight by talking to us on this Zoom platform by raising your hand on the Zoom, and then we'll recognize you and get you to ask the question directly. Alternatively, you can use that WhatsApp number. The number is +251 945502 Let me repeat that number again. +251 945502 All right, now let's move on to our questions. And the first question that we have today is coming from April, and she is a reporter with the New Humanitarian. Dr. John, this is for you. Regarding the confirmed case count reported by member states to the African Union, are these data also accompanied by information about how cases were reported, or in other words, what counts as a COVID-19 death? This is one. Is the Africa CDC aware of significant differences in the way that various countries classify and report COVID-19 deaths? For example, counting only direct causality from coronavirus versus the counting also of those with multiple premorbidities and comorbidities. Dr. John.
So let me say that this is a very important question. We continue to improve our mortality surveillance methodology, as we've admitted here previously. Prior to COVID-19, we as a public health agency were working very hard with a series of countries to improve the our ability to document mortality. So the data is exactly what we are receiving from the countries, and we continue to check that way. That is the reason why our data and that of WHO and countries is very, very aligned, because it's kind of data that people like Alex will provide to us, and we take that data and verify it and make sure that we report it accordingly there. So the question you talked about is very important. That is, what is the direct death related to COVID-19 and other associated? That is an area that we are working on very actively with member states to tease out, to understand exactly how many people are hospitalized, how many deaths result directly from COVID-19 and the associated deaths.
Could be a precursor to what's happening in the rest of the continent. I just wondered if you agree with them. Given the figures that you revealed just now, the sort of increase seems to be declining, actually. But is there any evidence of what he was warning about? And related to that last question more directly, are you confident that all the infections and deaths are being fully reported? In particular, there's been some suggestions, and I've read somewhere that reporting of deaths in many countries of any cause is not necessarily all that complete. I wouldn't mind. Yeah, thank you.
Yeah, Peter, thank you. I think let me start with the last question. As I've admitted before, we are mortality surveillance as a whole. Let's take COVID out of the picture for 1 second. On the continent has been an area that needs to be strengthened, so that we count exactly what their deaths. And we had developed a program at Africa CDC that was doing just that with several countries, and then COVID caught up there. So I think it's fair to say that the numbers that we are getting from the countries reflect what the countries are giving, but it doesn't necessarily capture the exact counts that may be occurring in the countries. That much we have to admit and live with that. That is community deaths. We just don't know, how the countries are capturing that. But it's an area that we need to work and improve on, because we really have to understand that. Just besides COVID-19, the essence of public health is really understanding how many people are actually born and how many people die and what they die of. And I think I always say that the continent has to be able to count everyone and make everyone count. That is the essence of mortality surveillance, which is a challenging area as a continent. With respect to what Mike Ryan indicated, I believe so that the South Africa situation is very concerning. As I indicated, South Africa now accounts for more than slightly over 50% of the cases on the continent. Several reasons might be attributed to this. South Africa is, as you saw earlier, is one of those countries that is doing the most aggressive testing. I think that they have been doing that since the beginning, and I think as you test more, you find more, and I think that is very, very important. And the second thing is, and this is a warning to the entire continent, is that as the virus seeds into vulnerable community populations around big cities, there's the less privileged areas, there's the slums and other. It becomes very difficult, and it can actually take hold very, very quickly. I think we are very, very concerned with that, and we have been concerned with that forever. Now, if you look at individual, let me just unpack certain regions of the. If you look at East Africa carefully, just a few weeks ago, Kenya was like number 3, okay, in terms of number of cases. You had Sudan and Somali and Djibouti. Kenya was like number 4, actually. But now Kenya has taken up very, very quickly and is probably the number 1 country in that region, as Alex was indicating. By the way, Uganda, congratulations for the remarkable work you are doing, Alex, with your 1,062 cases with 0 deaths for such a large country. It shows also and speaks to the experience that Uganda brings to bear with the Uganda Virus Research Institute and all the work you've done previously in the area of Ebola and other emerging infections in that area. So I think then you go to Central Africa and you look at Cameroon and the Democratic Republic of Congo. There too you see very sharp increases over the last couple of weeks. In West Africa, those countries to watch out will be Nigeria, Ghana, Cote d'Ivoire, and even Senegal. And those are, you can see the numbers are have taken up very, very quickly. So again, we are very concerned that in the manner in which these numbers are rising, but it calls to one thing, that we should strengthen a community engagement approach. There is no one-size-fits-all. The community engagement will be very critical, not just for contact tracing, but for making sure that we deliver our public health messages in each country within the exact context of that country.
Thank you very much, Dr. John, for those responses. I understand, Peter, you have another question, but let me first attend to others who are online, and I'll come back to you just now. Let me call upon Cara Anna from Associated Press. Hello, Anna. Hello, Cara.
Hi. Hope you can hear me okay. Thank you for this.
Thank you very well.
I just wanted to know how many health workers across the African continent have died of COVID-19. Thank you.
So, Cara, that's a very good question. I think we know the number of infections, but we don't yet have the exact counts of those that have died because of the COVID infection. So that is an area that will continue to improve. We just want to be sure that when we bring you information, it's as accurate as possible.
Thank you very much. Let's move on to Coletta. Coletta Wanjoni. Hello, Coletta.
Hello, can you hear me?
Yes, I can hear you very well. Please go ahead.
Okay, thank you very much. Doctor, I'd like you to kindly expound on the initiative that you launched with WHO about a panel of WHO and the Africa CDC, which you formed to provide independent scientific advice to support countries on issues of traditional medicine therapies. Then also, do we know how many countries have expressed interest to venture into herbal solutions? And finally, what is our status with proving the scientific efficacy of the Madagascar?
Thank you, Coletta, for those very important set of questions. First of all, the partnership with WHO yesterday was a partnership to advance African traditional medicine. And I think that was a very powerful statement that we as a continent want to promote traditional medicine and remedies as part of a possible solution to this. I've always maintained that the solution to fight against COVID-19 will be based on innovation, and we don't know where that innovation will come from. So we have to approach it with an open mind. Second thing is that traditional medicine and remedy in Africa is widely used, and we should promote it and encourage it, similar to what China does. I mean, if you go to many medicine stores on the continent, you see nice packages of China traditional herbal remedies, and I think that is a good example of what we as a continent should be doing. However, we should make sure that there are at least a couple of things are met. That is that the safety of the remedy is ensured, that the efficacy of that is ensured, and there's standards applied to that. That is, if you are producing a remedy against COVID-19 and John takes it, it should be the same that Peter is taking and what else. So that is standardization. So I think we are very interested in and keen to promote the remedy and also those qualities that come with it to ensure, to inspire confidence. That's what that task force will be doing. In terms of the countries that have expressed interest, now I don't recall that, but we know that several countries, including Madagascar, of course, Cameroon, and I believe Gabon and others have, we know that people have issued claims in those countries, not necessarily officials of those countries, but individuals, that they have remedies. So I think it was time to urgently put together this joint task force or technical working group with WHO and Africa CDC to promote and encourage that these remedies or these solutions are actually handled in the most appropriate and professional manner. I think, and again, the announcement yesterday and that committee should really lay to rest the issue of whether we are supporting it or not. I think absolutely we have all for traditional remedies. They have always constituted an important part of our health system, but we should make that formal and make that more organized. With respect to the Madagascar situation, we have formally reviewed what the government of Madagascar submitted to us as a dossier with the findings that informed them earlier to make the claim that they had the COVID-19 organic. We've written to them, we followed through with a note verbal to encourage that we agree on how to move forward with that, and we will be hopefully moving forward with that once the government of Madagascar reaches out to us.
Thank you very much for that response. Now we have two questions coming up, and these are from Della Russell, and she is with the Daily Graphic in Ghana. She says, Dr. John, how much is being committed to the traditional medicine research and development, and where is the funding coming from? So that's the first question. The second question is, will plant medicine research institutes available in member states be involved in the process?
So in terms, there's absolutely for now no allocations that I'm aware of, at least from the Africa CDC side, that is allocated for such. But again, we are very early on in this process of COVID-19. WHO has more experience in dealing with the traditional medicine group. We as Africa CDC, given our young history, is not yet into that at this point. However, if we are hoping that if the government of Madagascar comes through with and the collaboration, we will be able to find the resources to make sure that medication, the COVID-19 organic, is tested appropriately. So the short answer to that is that, at least as I'm aware, there is absolutely no dedicated resources for now. Remember, we are in an emergency and response mode, which nobody was preparing for this in January and February time frame. We are running and we are walking and running and doing everything at the same time. So with respect to the plan, institutes across the continent, there are so many institutes across the continent that are very capable of analyzing the content of any medicinal plant, and there will be no need to invent the wheel. All we need to do is to harness the existing assets that exist and create a network by region of institutions that can handle traditional remedies or herbal or plants to make sure that the active ingredients are identified and characterized.
All right, thank you very much, John. Peter, I understand you have a question for Alex. Are you still with us?
Yes, I am.
Please go ahead.
Yeah, I just really wanted to ask you, Doctor, it seemed quite remarkable that you have absolutely zero mortality rate from COVID-19, and I wondered if you could explain. I mean, Dr. John did make some reference to possible reasons. Perhaps you could give your input on that. Thank you.
Thank you very much, Peter. Yeah, I think one thing is, as I mentioned, that the emergence of COVID-19 found us already in Ebola response mode. We've responded to many of these major outbreaks. So we have a fairly robust surveillance system. We have good response mechanisms, and we had actually prepared literally all the pillars of our response in terms of surveillance, in terms of laboratory, in terms of case management, IPC. So we're fairly well set up to start that. So when COVID-19 came, we actually went into the response mode quite fast. And one thing is that by the time an alert comes in, we receive it in real time. So when we receive the alert in real time, the response team also responds in real time, including the emergency team that takes the patient, including the case investigation team, and then so actually manage these patients in real time. So that alone could actually avert death because of quick management of this patient, the quick transportation of this patient, because we have well set. The ambulance systems which are actually set up in different parts of the country that pick these people quite fast to take them to the isolation units. So I think that explains. The same thing also is that when you look at the pattern of our cases, we are actually recording mainly asymptomatic cases and then mild cases. We don't have cases that have actually the severe or critical forms. And so that also could explain, because we're having mild cases. So the quick management and then also the nature of the type of patient that we're having would explain actually why we're having zero deaths.
Explanation coming from Uganda. If I can just remind those of you who are watching, the speaker there was Dr. Alex Alio, and he's the director of the Uganda National Institute for Public Health. And this is all an effort by the African Union through the African CDC to also give member states the chance to explain to the continent some of the things that they're doing in their response to the COVID-19 pandemic. We move on now. I understand that Peter Mai from the BBC is online, and you have a question for Alex as well. Peter, good morning. Hello, Peter, please unmute your microphone.
Hello.
Hi, Peter.
Yes, hi. Yes, my question was on how Uganda and Africa CDC is accounting for foreigners who are being turned away at the border. Because I've noticed that, for example, you have Tanzanian truck drivers who are being turned away at the border. Then the figure for Tanzania has remained at what it was on 7th May.
All right, we can start with Dr. Alex.
Yes, Peter, I think that's quite a valid question. What actually happened was when you look at the time when we started, we were actually doing more testing than Kenya or Tanzania. Now, the major, by that point in time, actually, South Sudan was not yet recording many cases. And South Sudan shot up quite a number of cases around that time. Now, then you realize that we were actually doing the testing more than Kenya. Kenya now has started testing a little bit more than that. Now, at that time, because we were doing the testing and they were not doing the testing, it became a little bit problematic to us because we were actually spending a lot more on testing them and we were actually running up test kits quite fast. Now, what actually was discussed also at the interministerial level, and I think John mentioned this, was the discussion about the East African protocol. How do you manage patients along the way? When we decline them and they go back, who picks them? Because probably some of them go to the community and they are not picked. So the protocol of who picks them, because when we decline them entry, we expect their countries of origin to actually pick them and take them to isolation. Now, how they are picked and taken to isolation is one question. And this was discussed at the ministerial level, that actually countries need to pick them. Now, what is going on in Kenya or in Tanzania? I think I cannot answer it, but there have also been a problem there, picking these people and taking them to isolation. And this was discussed at the interministerial level.
So let me just add that we Africa CDC is working on, and this week at the end of the week, next Monday we'll be having the steering committee of the task force on the continent to devote the entire meeting on just these cross-border issues as countries begin to ease the lockdown and allow for movement across borders, like looking at testing at the borders and management of the cases, which is very important. If you listen to what Alex said earlier, I think if I captured where about 645 cases were picked across the borders and very few from the airport. So, and that is what you see mainly across the continent, be it in West Africa, Southern Africa, or East Africa. So we're taking that very seriously as we open up our economies there. They're focusing on these cross-border issues there. I just wanted to use this opportunity to again emphasize what Alex mentioned, that our threats are in three dimensions. I mean, as a whole. I mean, we have the vector-borne related viral threats, like the Zika viruses, which Alex and others had fought effectively in Uganda. The contacts, those threats that are virus-related, but contact to contact, like the Ebola, the Marburg virus, and then the respiratory. And each of these, even though you have a common way of approach, public health approach in fighting it, each of them requires specifics on how you deal with that. For example, when Ebola was raging out there, we were not required to wear masks, okay, because you really have to come in contact with a patient in order to get that. So I think it is our call from Africa CDC that countries, the National Public Health Institute, like the one Alex is heading, look at all three threats and develop strategies in country that would be appropriately adapted for a respiratory infection, a fast-moving respiratory infection like the COVID-19, the Ebola and Zika-like, and then Ebola and Marburg-like and Zika. So I think tomorrow we might be challenged with a vector-borne threat, and it will be very, very difficult to handle if all plans are not articulated and put in place.
We move on now to Sam Eferero, and he is with Africa Health Times in Nigeria. Dr. John, good morning. Nigeria has just approved a herbal preparation for the treatment of COVID-19. The registration agency, NAFDAC, said its approval only covers safety, that the company would need to conduct a clinical trial to ascertain its efficacy. Would you say this is in line with world standards for drug development? And is it okay to approve a drug for sale without ascertaining its efficacy first? That's Senator Ferraro from Nigeria.
So I will say that, as I said earlier, let me repeat what I said. I said, one, we're looking at a couple of things in these remedies. One is the safety. Second is a drug, if it's safe, is it efficacious, which is it addressing the disease, the outcomes, and either curing it or relieving sufferings in the patient. And then thirdly, are you doing that in a standardized fashion? So I think those are the characteristics that we'll be looking forward to any remedy, traditional remedy or herbal remedy that is out there. And I've not seen the Nigeria product. Thanks for bringing that to attention. We will be engaging with the Nigerian authority to see and learn more about that product. But those are the areas that will be of interest to us, and we encourage countries to fulfill those areas of critical interest before putting out the remedy.
Up next, we have a question from Sarah Jerving with DEVEX, and she says, you have mentioned that testing in the Central African region is low. Could you elaborate on why this is so, and which countries in particular are of concern?
So testing in Central Africa, as I indicated, if my recollection as of this morning is correct, is about 330,000 for the entire region, ranging from Chad to Burundi and going through the DRC. So overall, and that's a large number of a collection of countries, about 9 or 10 countries in that sub-region. And there is a need to ramp that up, and we've now developed a task force that is looking at that very carefully. I would not be able to give you the exact numbers by countries, just because I don't have it in front of me, but we have that in our directory. If you send me an email after this, I will quickly send you the details by country. And the reason is simply those that we have that has challenged the continent previously. One is access to appropriate testing. The main driver behind the main testing platform that we are using is the PCR-based testing, the polymerase chain reaction-based testing, which is challenged in terms of the ability to collect specimens and test them at specific testing sites. A country like Chad only has about 1 or 2 testing sites, so it becomes very, very difficult to ramp up testing. So we are now working with companies like Gene Expert to get large amount of them and supply that in Central Africa, just because we believe that you already have those Gene Experts machines that were there already for TB testing that can be used to ramp this up very quickly. Over time, we are very positive that more appropriate rapid diagnostic tests, especially the antigen tests, will be available, and that will begin to unlock that ability for countries to test quickly. I would just like to end up there by saying that we should all be reminding countries that there's the African Medical Supply Platform that was launched by President Ramaphosa, and that Strive Masiwa and us work in establishing. And it's very easy platform. Countries should be able to go in there and buy reagents, or which is their quotas have been allocated. Again, this is a strong message that I really like to let countries be aware of.
Thank you very much for that response. We are almost at 11 o'clock, but the producer tells me that we can have an extra 15 minutes because we have a number of other questions that we need to attend to. So I will now call upon Halima Atumani, who is online. Halima, please tell us the agency that you're representing and then ask your question. Hello, Halima, please unmute your microphone. Halima?
Can you hear me now?
I can hear you. Please tell us the institution and then ask your question.
Yes, please. My name is Halima Athmani. I correspond for Voice of America. I would like to ask Dr. Alex Ario. He says that we are seeing more community infections in Uganda. Why is that the case? But also the question of security officers whose numbers are also going higher. Every time we see them on the streets, they do not have any PPE on. What is being done to ensure that people who are frontline workers get the PPE? Because it says even the PPE that is available right now is not going to last us a couple of months as Uganda. Thank you.
Okay, so thank you very much, Alima, for that question. I think when you look at we actually tried to look at our pattern infections. And when we did the rapid assessments to determine community transmission, as I mentioned, we picked quite a number. We looked at the trap routes, we looked at the different communities, we looked at schools, we looked at markets, we looked at fishermen, we looked at different communities. But by that time, we actually did not find community transmissions as such. The three that tested positive, the 24,000 samples that we tested, actually had evidence to talk about. Now, with time, we started noticing something going on, which was not right. One, I think we started noticing that even where we are having these community transmissions, still there is some linkage to the cross-border movements. So the movements across borders and the people who had a kind of reduced vigilance in maintaining the prevention measures would have actually explained why we started having community transmission. The foreign truck drivers, and even the Ugandan truck drivers that actually started testing positive, when we actually even looked at the pattern, we looked at the pattern of contacts between Ugandan truck drivers, the foreign truck drivers, the kind of contact they're having. And when we try to tease out all these things, we realize that among these people, there was actually people who were having contact with the community without having the prevention measures observed. And that would actually explain, because in the community transmissions, when you look at where we have sustained community transmission, those are actually still even border districts. So there's still some element of linkage to the truck drivers or the cross-border. Now, for the security people who are not actually putting on these measures, the presidential directive is very clear, and the recommendation by the National Task Force, and scientific knowledge, that everybody should put on masks. But they don't put on masks. They force other people to put on masks, but they don't put on masks themselves. And this is something that we have observed over time. And now, as I say, we've actually had 54 of them actually getting infected. And now there's also a direct attempt to them to actually show them that they are having their people getting infected, so they need to enforce prevention measures amongst the different security personnel.
Thank you very much. Let me move on to Mark Schengel. Mark?
From what I understand, a few months ago already, the Ministry of Health here indicated that some corona patients here were treated with hydroxychloroquine. A lot has been said about that medicine. Can you elaborate a bit on that? Is that indeed the case, and how many people have been treated using that? Has it given any complications to anybody, or are you aware? Thank you.
Okay, thank you very much. Thank you very much, Mark. I think the treatment with the hydroxychloroquine, which was mentioned earlier, that was the time when there were all everybody was like in the firefighting. Nobody understood COVID very well. So people were trying to look at all sorts of things. But there's a scientific committee and even the committee which I see it and all that. We looked at it and we looked at the pros and cons and we realized that we needed to have very clear studies done. And of course, at that point in time, we were informed that there were a lot of clinical trials going on to determine the effects of hydroxychloroquine. And it was found actually to have a lot of side effects. And so the official position of the Ministry of Health to continue treatment with that kind of thing was actually stopped. So it never became the official position of the ministry or government in Uganda to treat with hydroxychloroquine.
Dr. John, do you wish to make a comment on that?
Yeah, just to say that we have issued guidance to countries that, as far as Africa CDC is concerned, hydrochloroquine and chloroquine should only be administered in the context of clinical trials. And we issued that a long time ago, and we were also very, it was also interesting to see that WHO had to stop one of the solidarity trials that was using hydrochloroquine. So I think our guidance still remains that, except patients are enrolled in a clinical trial, they shouldn't be used widely, mainly because of the side effects.
All right, thank you very much. Maureen Adudan. Maureen, good morning.
Good morning to you. Are you able to hear me?
We can hear you very well. Please tell us your agency and ask your question.
Thank you so much, ma'am. My name is Maureen. I work with CDC. I acknowledge the very good discussions that we've had in the presentations from both our panelists. My question is to Dr. John. We recognize the challenges that the COVID-19 pandemic has put particularly in our health systems and the pressures therein that have compromised service delivery, not just for Corona, but beyond. I'm wondering, for Africa CDC, is there a mechanism in place for monitoring or tracking the disruption of continuity of essential services in countries and the effort that are being put in place to advocate for the continuity of essential services alongside the unaffected COVID-19 response? Over to you. Thank you.
Yes, Maureen, that is a very good question, very pertinent. If you look at our continental strategy, the joint continental strategy that has been guiding us, there are three pillars to that. One is our focus to limit transmission of COVID. The second is to limit harm. And third and lastly is to limit, second is to limit deaths, and the last one is to limit harm. And we are very deliberate when we developed that in February. The harm here was intended to mean the harm on the economy as well as the harm on non-COVID related infections, because we know for sure that pandemics or outbreaks always result to a disruption to several services. In West Africa, for example, during the Ebola outbreak in Sierra Leone, Liberia, and Guinea, HIV services were decreased about 50%. And TB services almost about 47%, and about 1 million children went without vaccination due to the Ebola outbreak. So we expect similar to occur here. So we are really working very closely with our partners, including the UNAIDS for the HIV program, to really raise that voice of advocacy to say, look, be mindful that HIV kills about 500,000 people on the continent every year. A combination of HIV, TB, and malaria will result to about 1.2 million deaths a year. So we really have to be mindful of that. Immunization programs will definitely suffer because of this. As I said, we saw that in West Africa. We will see that now with this the COVID infection. So we are really actively engaged. It's an integral part of our strategy under pillar number 3.
Thank you very much. We have 3 more questions to go. And this one is coming from Peter van Houston, and he's online. Hello, Peter. Hello, Peter, I can see you. Please tell us your institution and ask your question. Hello, Peter. All right, I think we'll come back to Peter a bit later on. Let's move on to Fred. Fred Muvunyi. Hello, Fred.
Hi, can you hear me?
Yes, we can hear you. Please tell us where you're calling from, your institution, and then ask your question.
My name is Fred. I work for Deutsche Welle. Deutsche Welle is German international broadcaster. I wanted to ask the director of CDC Africa, how do you explain the surge of COVID-19 cases in countries like Nigeria, South Africa, Egypt? Yet they have put up measures to curb the pandemic from the early beginning. In comparison to African countries like Tanzania, Burundi, which actually did almost nothing, there are few cases there. How do you explain that? And if you may have time, can you also tell us if there are shining lights, a country that is doing well, that deserve praises at the moment? Thank you.
So, Peter, very good question. Let me perhaps start by the last question, which you framed very well. There's many countries in Africa that are doing well, and in this context of COVID-19. One shining example is Uganda, with 1,062 cases. I think that Uganda is a big country, and if I'm not mistaken, the population is over 40-something million. Alex, correct me here. And to have had 1,062 cases and 0 deaths, that is a good example there. Rwanda, is a very good example of what they are doing. They are using community, just the strategy we recommended, and the launching of the PAC initiative, the Partnership to Accelerate COVID Testing, which is underpinned by the testing, the tracing, and the treatment. Rwanda has deployed more than 1,000 something community workers to help with contact tracing. Look at Angola, look at Mozambique. They're all around 1,000 cases or below, okay? So I think there is a very good, a whole series of countries, Mauritius, that have really done very, very well. So we should always keep that in mind and again, as you said, use those as, and understand why those countries are doing that well. With respect to South Africa, Nigeria situation, again, Nigeria is a big country. It's a country with a population of over 200 million inhabitants. As we speak, the total number of COVID infections recorded in Nigeria so far is about 35,000. And you have to be able to praise the government of Nigeria and the Nigeria CDC, which is a similar institution to what Alex runs in Uganda, because without their efforts, the numbers could have been in skyrocketing. We are seeing what is happening in Brazil, okay, and see what is happening in India and other places there. So I think the numbers are high in Nigeria, but again, we put that in the context of that country and the context of big cities like Abuja and Lagos. You can actually cannot but really congratulate them for the tremendous efforts they have put in place to fighting a disease of this nature in a very, very difficult context. Okay, they're very challenging situations there. So I think I explained the South Africa situation earlier, that South Africa is the country with the most aggressive testing in as far as I can say in Africa, and there's no doubt that they are finding a large number of cases. Secondly, that it is very possible that the virus has now seeded itself into vulnerable populations in South Africa. The one thing pandemics do or outbreaks is that they take advantage of disparities that exist in any situation and amplify that. So it's known, and it is is my worry that you see this more and more in many capital cities, and our capital cities have a lot of shanty towns around them, slums, and once the virus seeds itself into these populations, it will become, you begin to see changes in dynamics there. So I think, as Alex said, community transmission is occurring now across the board in Africa, including in Ethiopia, where we reside. So I think it's an evolving situation. What we did as a continent in the first phase of this was remarkable. It was under strong coordination from the African Union Commission and from President Ramaphosa as the chair of the African Union. And the countries locked down very quickly. If you recall, lockdowns occur when 1 or 2 cases had been reported. And now countries are unlocking their economies, and you expect to see cases rise. But as they unlock their economies, there are a couple of things we must do. We must intensify public health measures. That is, scale up testing, scale up surveillance, so that you can pick the hotspots and fight them very quickly, so that you can protect our economies. We cannot keep our economies in permanent lockdown. So I think, again, expect to see that numbers will increase across the continent. With respect to Burundi and Tanzania, Burundi has engaged us actively. We'll be deploying large number of community workers there. There will be a renewed opportunity to really understand what is happening in Burundi. So we are really excited with a renewed opportunity to support Burundi. And Tanzania, we continue to expect that the government will cooperate with the last numbers we got from Tanzania. We had 509 cases. We continue to expect that they will be giving us the updated situation. And the last time they reported was in May, and we are in late July. We really will be very, very pleased to see a renewed engagement with Tanzania.
Thank you very much, John. We move on now to West Africa, and we are going to hear from Ibrahim Ba, and he is with the Gambia iAfrica TV. Hello, Ibrahim. Ibrahim, good morning. Hello, Ibrahim, are you able to talk to us? All right, it looks like Ibrahim is having some challenges. Perhaps we'll be able to come back to him later. Let me move on to George Obulutsa with Reuters. Good morning, George. Hello, George.
Good morning, can you hear me?
Good morning, we can hear you. Please give us the institution that you are representing and then ask the question.
George Obuluta, Reuters News. Just seeking comment from Africa CDC with regard to what the assessment is of what is looking like a red environment worldwide. The sure supply of vaccines and before going to production. Good example, the US, which has already said it will pay 1.95 billion, 500 million vaccines from Pfizer and BioNTech to prove safe and effective.
George, I'll confess that I didn't really understand the question, but I believe you talked about access to vaccines and countries already doing pre-market arrangements, if that is correct.
Yes, yes.
So as a continent, the couple of things we have to, the general public statements have been very appropriate. As you can imagine, there's been a call for a people's vaccine, and there's been a public statement made with several leaders in the world saying that there should be equitable access to vaccines. But we as a continent have to be mindful that we cannot and should not just contain ourselves with this public declaration, that we should, that ourselves as a continent begin to play a strong role in this, in terms of vaccine development, manufacturing, and access. So it is because of that that, if you recall, George, we had a very successful conference on the 24th, 25th of June, where over 3,000 people registered, and President Ramaphosa, in his capacity as the chair of the AU, presided over the meeting, and including the chairperson of the African Union Commission, Chairperson Faki. The goal of that was to really make our position as a continent clear, to say that we are not just going to be waiting for our own fate to be decided outside of the continent, that we were organized, and we want to play a key role in the whole course of the process of access, what are called end-to-end access for COVID vaccine, including participating in clinical trials. We have since launched, as you recall, last week, from last week's discussion, what we are calling the CONVAC, the Consortium for COVID-19 Clinical Trials platform, which is moving on very, very well. And we've now engaged with different vaccine manufacturers. We've written to them. We are hoping that we will start engaging them in several dialogues. We are also working through our different partners, including the banks in Africa, like the Exim Bank in Egypt, to look at mechanisms that the continent can actually also prepare itself for the vaccine, COVID vaccines, dialogue, and also procurement. And lastly, we will be releasing a strategic plan and framework for the continent very soon that will reflect our different priorities and action items that the continent will need to take to ensure that we are not left behind. We are always reminded of the situation in 1996 when HIV drugs were made available, and it took us almost 7 years until from 1996 to 2002, 2003, where they became accessible to the continent. If that will happen now with the vaccine, it will be catastrophic for the continent. I think we are taking that that issue very, very seriously, and you'll be hearing from us in the coming weeks.
All right, so we have Michael Omare from Tunacheki, and he says, according to Dr. Mike Ryan of the WHO, other African countries stand a huge risk of experiencing huge infection spikes like those being experienced in South Africa. The question is, what can other African countries do on the ground that is different to prevent the kind of peak that South Africa is facing? This is one question from Michael. The second question is, seeing as though South Africa followed many of the guidelines used by the Africa CDC and the WHO, why do you think that they are experiencing this peak, and why is it that they are the world's fifth most infected country? Two questions there from Michael.
So thank you. Very good questions there. There is a couple of things. The continent as a whole still has a chance to fight back in a successful manner. And this is why, of the 55 countries in Africa, 37 of them have reported less than 5,000 COVID cases. That is very encouraging. It means that the strategy that we are recommending, which is the PACT strategy underpinned by the ability to test, to trace, and to treat, is very, very valid there, because at a certain threshold, it will become difficult to implement contact tracing. The tools that we have in our toolkit now is what I'm describing, which is public health measures to do that massively and aggressively. Use contact tracers, use thousands of them to support their testing. If testing alone will not suffice, this testing has to be backed by a quick turnaround time so that you can isolate those who are infected, find their contacts, do the same thing, and then bring those who are have been infected to begin to administer treatment. And as Alex said, fortunately, many countries are reporting a large number of patients that are asymptomatic, which is a good thing, which means, but we now know that countries are beginning to see their hospital systems overwhelmed because they need to manage that. So the last thing I'll say is that this has to be strongly supported by community leadership and community response. we cannot extrapolate the measures in the West into Africa because our context is very different. The community leadership has to play a very strong role here. Community engagement is key. That is, the religious leaders, civil society has to play a critical role so that we can find solutions from within our communities that will be adapted. And lastly, we just have to make sure that we mask ourselves 100% across the continent. What I call universal masking of the continent is very important at this critical stage. So again, repeat what I said, we still have a strong chance of pushing back this pandemic as many countries still have less than 5,000 cases. And if you add the 7 countries that have less than 10,000 cases, that number goes up to 40-something countries, so where you can still apply those measures there. Again, if the virus takes hold in a vulnerable population, it spreads very quickly, like wildfire. I believe that is what we are seeing in South Africa now.
All right, thank you very much. I think now we are going into our last question, and let me invite Rhoda. Rhoda, are you available? Good morning, Rhoda. All right, perhaps we can finish with John Johannes of Sudan. Hello, John. Okay, it looks like both colleagues are not able to join us at this time. I trust that they will try again next week when we come back at the same time on Thursday for another briefing from the Africa CDC. Right now, it remains my pleasure to thank very much the Director of the CDC, Dr. John Nkengasong, and also our guest for today who was representing Uganda, Dr. Alex Ario, who is the Director of the National Institute in Uganda. Thank you very much, both doctors, for joining us. And for colleagues who may want to look at this briefing again, it remains available on demand on the different channels that we've mentioned. Let me just repeat them. You can watch it again on the Africa CDC YouTube channel. You can watch it on the African Union and Africa CDC Facebook pages. And you can also watch it on the African Union. So you have a variety of channels you can use to catch up. And then I remember that Sarah had an issue that needed to be resolved via email. Don't have our email address ready with you. You can use the WhatsApp number that we are using for this session, and that is +251 945502 And Neke will then be able to forward that question to Dr. John for you. Otherwise, thank you very much, everyone, for joining us. We look forward to joining you again next week on Thursday at 11 a.m.